delegates, whoever they are joining, they'll not feel blank kind of this thing.
Is there a separate link for the delegates or the same
Yes,
link?
sir. Yes, sir. For delegates, separate link, sir.
Okay, okay.
So Shashikiran sir, we are live, right? So once you say okay, then we will start the session, sir.
Yeah. Moti sir is about to join. Sir has just called me. He'll join in another 1 or 2 minutes. Once he joins, we'll go.
Yes.
Okay. Good evening, Moti sir. Yeah, Mr. Vasu. Sir has joined. Yeah, we can proceed. Vasu, please unmute.
So very good evening to one and all. And on behalf of Team Corona Remedies, we welcome all the delegates and the dignitaries who has joined for this today's virtual CME. And to organize this virtual CME, we are thankful to Academy of Pediatrics Karnataka chapter and Mysore Indian Academy of Pediatrics Mysore chapter. And we also extend our special thanks to SN Moti sir and Prashant sir and Savita ma'am and Dr. Shankar Prasad sir and Dr. Trupti ma'am. We also extend our warm regards to Shashikiran sir, who has ably accepted our invitation to share his valuable insights on nocturnal enuresis. Which I'm sure this topic will be most interested and excited topic for all pediatricians, and definitely you all will be benefited from the insights of the expert insights of the Shashikiran sir. So in fact, actually Shashikiran sir has delivered his valuable insights on nocturnal enuresis at IAP Cochin as well, Pedican Cochin. And no doubt the hall was crowded and people were like so excited to hear from him. And now everyone will get a more opportunity because it's almost a 45-minute session. Star will share his valuable insights on the nocturnal enuresis. So you will be having a more clarity and no doubt in addressing this issue in future. And to take this, before starting this session, we'll have a virtual lamp lighting, and I would request everyone to join for this virtual lamp lighting. So now I would like to, I would request Shankar Prasad sir to take this today's proceedings ahead. Shankar Prasad sir. Now the virtual stage is with you, sir. Shankar Prasad sir. Maybe we will can we ask Moti sir to share his welcome note if it's possible? SN Moti sir.
I think you can call them over phone and inform them.
ನಾ ಇಡ್ತೀನಿ ಅದ
ಶಶಿ ಆಡಿಯನ್ಸ್ ಅಲ್ಲಿ ಇದಾರೆ, ಆಡಿಯನ್ಸ್ ಅಲ್ಲಿ ವೇಟಿಂಗ್ ಇದಾರೆ ತುಂಬಾ.
ಇದಾರೆ ಸರ್.
ಸರಿ ಸರಿ, ಮೂರ್ತಿ ಸರಿ ಫೋನ್ ಮಾಡ್ಬೇಕಿತ್ತು ಅವ್ರಿಗೆ.
ಮಾಡಿದ್ ಇಬ್ರಿಗೂ ಮಾತಾಡಿದೆ ಸರ್ ಈಗ, ಶಂಕರ್ಗುನು ಮೂರ್ತಿ ಸರ್ಗುನು ಇದಾರೆ. ಶಂಕರ್ ಆಕ್ಚುಲಿ ಮಾತಾಡ್ತಿದ್ದಾನಂತೆ, ಅದಿಲ್ಲಿ ಬರ್ತಿಲ್ಲ ಅಷ್ಟೇ.
ಸರ್ ಮೋತಿ ಸರ್ದು ವಿಡಿಯೋ ಮತ್ತೆ ವಾಯ್ಸ್ ಎರಡು ರೀಚ್ ಆಗ್ತಿಲ್ಲ, ಅನ್ಮ್ಯೂಟ್ ಮಾಡಬೇಕು ಅಂತ ಹೇಳ್ತಾ ಇದ್ದಾರೆ.
Prashant sir,
ಮೋತಿ
maybe you
ಸರ್
will...
ಆನ್ಲೈನ್ ಅಲ್ಲೇ ಇಲ್ಲ. ಮೋತಿ ಸರ್ ಬಂದ್ಬಿಟ್ಟು ಹೋಗಿದ್ದಾರೆ. ಅವ್ರದ್ದೇನೋ ಪ್ರಾಬ್ಲಮ್ ಆಗಿದೆಯಾ ಅಂತ.
Prashant sir, maybe you would like to share your...
Hello, now I think Moti sir is logged in now, just now.
Again,
Sir, sir, is my voice audible?
Yes, Shankar, please go ahead.
A very good evening to one and all. I welcome you all to today's scientific session on nocturnal enuresis, which is a common pediatric condition seen in the office practice. To begin with, I invite Dr. S.N. Moti. Sir is president of IAP Karnataka branch and is chairman of SHASHIKIRAN Hospital. So I welcome sir to give the presidential address. Over to you, sir.
Moti sir, you can unmute, sir.
Okay, am I audible now?
Yes, sir, you're audible, please. Yes, sir.
Okay. Okay. Good evening, listeners. It gives me immense pleasure to get this first ever webinar in IAP Mysore district branch, which was set up by Dr. SHASHIKIRAN, Dr. Prashant, Dr. Madam Savita, and Shankar Prasad putting these efforts to get this along. I think we need to do this more often so that we can get ourselves connected and understand what are the priority health areas that we can learn from our own experts in the city of Mysore, so that we can get this on an ongoing basis. Okay. Am I audible now?
Yes, sir, you're audible.
Yes, sir. So, I think without wasting much time, let's all sit and listen to Dr. SHASHIKIRAN's presentation about nocturnal enuresis, which is sometimes distressing, very frustrating and challenging problem which children and adolescents and even parents face, and how we can really circumvent these challenges, how to get across so that we can provide considerable comfort to the families. Over to you, Dr. SHASHIKIRAN. And I recognize the presence of Dr. M.R. Prashant, our district branch president, Dr. S.N. Prashad, professor of pediatrics in JSS, and Madam Savita, professor in pediatrics in MMC RI. Over to you, SHASHIKIRAN. After we listen to you, I think we'll also allocate some time for Q&A so that we can learn more and more from this. Thank you.
Thank you, sir. I request Dr. Prashant M.R., President of Mysore IAP, to please give us remarks.
Good evening, everyone. So, respected seniors, the Moti sir. So, he is a state IAP president. Today's chairperson, Prashant S.N. sir, is a professor and HOD JSS Medical College Department of Pediatrics. And Dr. Savita madam, she is a professor and HOD. So, in Mysore Medical College Department of Pediatrics. And today, I think we are going to discuss about nocturnal enuresis. It is though it is a under-reported diagnosis. It is a very commonly seen in pediatric age group as well. At times, it may be difficult to even treat that condition. So I would expect and I would wish good luck to today's speaker, Dr. SHASHIKIRAN, to enlighten us on nocturnal enuresis. Over to you, the speaker.
Thank you, sir. It's my privilege to introduce today's chairpersons. Both of them are esteemed pediatricians in the Mysore city. Firstly, we have Dr. Prashant SN. Sir is a professor and head of Department of Pediatrics affiliated to JSS Medical College and Hospital. The renowned pediatrician and an academician. I welcome you, sir, to chair the session. We also have Dr. Savita MR. Ma'am is a professor and head of the department Pediatrics, Mysore Medical College and Research Institute. She's a well-known teacher of mine and many of us here, and she's a very good academician. It is a privilege to see Madam chairing the session. I welcome you, ma'am.
Thank you, Dr. Shankar Prasad.
Yes, ma'am. Over to the chairpersons to begin the session.
Yeah, good evening, everyone. I'm Dr. Prashant SN. I'm very happy for the topic chosen today. Every one of us in our clinical practice, even in hospital, we see a lot of cases. And at some stage, we get stuck about the treatment. So to discuss about this, we have a very good speaker. It's none other than my close friend, Dr. SHASHIKIRAN, who has done MD, DNB Pediatrics, DM and DRNB Nephrology, presently working as assistant professor and in charge head of the institute, Affiliations Institute of Nephrology, Mysore, Karnataka. I'm very glad to introduce him. Major achievement is he's the first to start pediatric nephrology services in Mysore. And right now he's the secretary IAP Karnataka State 2024. He was secretary Mysore IAP 2021. And he has around 20 publications in national and international journals in pediatrics and nephrology. Very happy for you, SHASHIKIRAN. Wish you all the best. Please go ahead.
Thank you so much, sir. I hope the screen is visible.
Yes,
Yeah,
it is
visible. Visible and very nicely audible also.
Okay. At the outset, I would like to thank IAP Karnataka and IAP Mysore for giving me this opportunity. I've been listening since the last 5 to 6 minutes, and few of points which I was able to note down here was it's not an uncommon phenomena. It is, and sir said very important thing, that it is not just distressing to the child or the person who has been affected, but to the entire family. And it becomes sometimes very bothering or troublesome in its management. It's very true. Enuresis is one such entity which is neither a disease nor it is normal. So when exactly is to be considered as a disease or as a problem, how to go about it is what we are going to discuss in the next 30 to 40 minutes. So I'd like to begin with a case scenario. We have a 9-year-old male child who is brought by her mother with complaints of bedwetting. Child has been wetting on most days of the week, some nights even twice per night. Child has had attained dry by day at approximately 2 years of age. However, he hasn't remained dry by night continuously for more than a month. Never has he remained dry by night for a duration lasting more than 1 month. Occasionally, 1 or 2 nights he might be dry. Otherwise, most of the nights he is wetting his bed. One more history is that his father has had a bedwetting in the childhood, which has improved when he had almost reached by 10 to 11 years when he was studying in a 6th standard. On further inquiry, the mother says that the child is very reluctant to visit his grandparents or cousins' home if there is a necessity to stay overnight. And compared to his sibling, he's not socialized. On examination, by and large, the child looks normal. Isn't this a very common scenario in our day-to-day practice where the child is having this issue of bedwetting? And most often than not, as sir had already said, it is neglected because it is from the caregiver's side, they feel that if one of the parent or one of the other child has had a similar problem in the past, they feel that this is a okay scenario. It is just a deviation from what is normal. And as time passes by, it gets better. Some might even feel that there is nothing much they can do about it. And some may feel that they have not been good parents, something they are missing out. That is why the child is doing like this. And the worst is, sometimes they blame the child for wetting its bed, or they blame themselves that their parenting has not been good. So all these things which we have to address when we are seeing a child who is having the problem of enuresis are simply called bedwetting. Keeping all these things in mind, my topic will proceed in the following headings. We'll first go through the terminology and the epidemiology of enuresis. Then we'll throw some light on the symptomatology and what is the pathophysiology underlying a child with enuresis. We'll look into the few points of how to evaluate a child with enuresis and the bladder diary. We'll look into what are the management options that we have, and we'll end with some take-home messages. So nocturnal enuresis, or in simple words, bedwetting, is urine leakage in discrete amounts occurring during the night in discrete episodes while the child is asleep in a child who is more than 5 years of age. So if a child less than 5 years of age is passing urine at night, it is considered relatively normal. However, children's drive-by night development occurs at different age. Usually, the bladder control is attained by around 2 years during the day. However, the nighttime control much lags behind the daytime control. So if this nighttime control has not yet been attained by 5 years of age or beyond, then it is called nocturnal enuresis. So is it all children who wet their bed at night beyond 5 years, is it abnormal? I wouldn't say that. But now let us look into certain things which differentiates a normal variation from a problematic enuresis. So to go ahead with this, nocturnal enuresis is divided into two main categories. One is monosymptomatic nocturnal enuresis and non-monosymptomatic nocturnal enuresis. As the name suggests, if the problem is only about bedwetting without any other features of lower urinary tract symptoms, then it is monosymptomatic nocturnal enuresis. However, if there is any of the features of lower urinary tract symptoms like urgency, frequency, dribbling, poor urinary stream, daytime wetting, or any holding maneuvers, then it is non-monosymptomatic nocturnal enuresis. We would like to say that nocturnal enuresis is not a disease per se and rather a symptom of an underlying condition. We'll try to understand it further why. See, as I said, enuresis can be either monosymptomatic or non-monosymptomatic, or it can be primary or secondary. Like any other disease, primary means when we don't have any underlying pinpointable etiology. If there is a secondary cause, then it is secondary. So the important distinction, so if we consider this four main broad terminology, as I said, that is primary monosymptomatic, primary non-monosymptomatic, secondary monosymptomatic, and secondary non-monosymptomatic. The very most important distinction that we have to make out is whether it is a monosymptomatic or non-monosymptomatic. That is the first distinction we have to make out when the child comes to us with complaints of bedwetting. Because if it is a non-monosymptomatic nocturnal enuresis, then the disease spectrum is totally different. It requires a extensive group of physicians, surgeons, psychologists, all getting involved in it. While if it is a primary monosymptomatic nocturnal enuresis, it can be treated at the primary physician level. And for the next 20 minutes or so, I'll be concentrating about how to differentiate between the monosymptomatic versus non-monosymptomatic nocturnal enuresis and who requires therapy in a child who has monosymptomatic nocturnal enuresis. A small note about what is primary monosymptomatic nocturnal emesis and secondary monosymptomatic nocturnal emesis. Primary means the child has not attained dry by night at all. As I discussed in the case which I presented in the beginning of my talk, the child has never attained dry by night for a significant period of time. There is an occasional dry night, but that dry by night has not persisted for a duration of 6 months. If the child has a dry by night for a duration of 6 months and then it starts bedwetting again, that is called secondary monosymptomatic nocturnal emesis. I hope I have made it clear about the differentiation between monosymptomatic versus non-monosymptomatic, because this is very much necessary because our management depends upon this distinction. Presence of any lower urinary tract symptoms means it is non-monosymptomatic. Presence of only bedwetting, it is monosymptomatic. If there is a period of dry by night of a duration of 6 months or so, then reoccurrence of bedwetting is called secondary monosymptomatic nocturnal emesis, while a child with primary monosymptomatic nocturnal emesis has never attained dry by night for a duration lasting beyond 6 months. So most of the days is still passed from his birth. So how common is this disease? Is it uncommon? Here, beyond 5 years, various studies have shown a prevalence rate somewhere ranging between 10 to 20%, and a little male preponderance has been noted. And each passing year, as the child matures, there is a reduction in the prevalence of bedwetting by around 3% per year. So by the age of 10 to 12 years, around 3% of the children bedwet, and that remains relatively static. Meaning, whatever bedwetting which has a spontaneous resolution occurs by the age of 10 to 12 years. So even we can make out that by 9 years also significant reduction has been noted. So the one which is persisting beyond this period usually may not subside by itself without treatment. So these group of children definitely require some amount of assistance from our community. So is this same in India? Yes. We say that around 1 in 8 children is suffering from bedwetting. As I mentioned, around 12 to 14% is the range at 5 to 6 years of age, which gradually reduces by around 3% and reaches around 3 to 4% by the age of 10 to 12. So is there any variation between male and female? As I told you, definitely there's a slight male preponderance. Few studies have shown equal preponderance in both male and female. The prevalence is around 7 to 14% in different various studies from India. So the prevalence rate varies across the world, but by and large they are similar. Based on the sample which they have taken and the age range that have included, the prevalence has varied in different parts of the world. But by and large, let's remember that around 10 to 15% at 5 years of age reduces by 3%, reaches around 3% by 10 to 12 years, which usually do not subside by itself. So what I have tried to show in this chart is there is severity grading of bedwetting. If the child is wetting less than 3 nights in a week, then it is mild bedwetting symptoms. If the child is wetting on all the days, all 7 nights a week, then it is very severe. If it is between 3 to 6, then it is moderate to severe symptoms. As I told you, there is a 3% reduction in the prevalence. So who are those who have a chance of spontaneous resolution? These are the children, that is, those with mild symptoms are the ones which have a chance of spontaneous resolution. So here we can make out that at age 5 years, almost 56% of the children have only mild symptoms, and children with severe symptoms constitute only around 14%. While at the age of 19 years, the severe symptoms contribute around 49%, as against mild symptoms with only 10%. So what I mean to say is that those children with milder symptoms tend to resolve spontaneously, and those with severe symptoms, even at a young age of 5 years, tend to persist at the age of adolescence or beyond 18 to 19 years. So these children who have severe symptoms, who are wetting almost all nights, need to have medical attention. So 2 points I've already told you who need medical attention. Let us see what causes this enuresis. The conventional understanding when I was a undergraduate or a postgraduate was that these enuretic children tend to sleep deep. So they don't want to get up and they usually pass urine while at sleep. But the converse is what we have found out in the research studies, latest studies. They actually do not sleep deep and they have a lot of sleep and arousal disturbances. They have repeated awakening and thereby their sleep is not satisfactory and hence the child is reluctant to get up from the bed, fearing that he will not get back sleep again and passes urine in the bed. That is what is a more established phenomenon now. But along with this, the most important pathophysiology that which is we are learning is the abnormal circadian rhythm of antidiuretic hormone secretion. I'll explain about it in a little later in the upcoming slides. The AVP has a characteristic increased production at night, which is not seen in those children who are having enuresis. Along with this, enuresis as a part of psychosomatic manifestation, as a part of those children who have bladder detrusor and sphincter dysfunction, abnormal bladder reservoir function, some genetic predisposition, developmental delay, and other comorbidities like constipation, bowel and bladder voiding dysfunction, all these have contributed to enuresis. So that is why it is important for us to differentiate between monosymptomatic versus non-monosymptomatic. So if there are symptoms of lower urinary tract symptoms, then we have to think of conditions like this, bladder detrusor sphincter dysfunction. However, in a primary monosymptomatic nocturnal enuresis, the predominant pathophysiology that we have observed is the abnormal circadian rhythm of AVP secretion, as well as the bladder reservoir function. These two are predominantly involved. We'll understand it in the upcoming slides. So this is what I was talking about. Here, the blue line represents children who had nocturnal polyuria versus those who do not have nocturnal polyuria. What I mean by the term nocturnal polyuria is these are the children who are passing more urine at night. By definition, it is 130% of the bladder capacity. Bladder capacity is calculated by the formula for age dependent, that is 30 into age in years plus. Let us look up the formula on the side. But what I want to stress upon here is, in a normal individual, where the AVP production at night is increasing, is not noted in a child who is having this nocturnal polyuria. Hence, who is having nocturnal polyuria. So because AVP is not increasing its production at night, there is a significant amount of urine that is produced even at night. While in a normal individual, there is a significant drop in the amount of urine that is produced. So it is very important to identify children whether they have nocturnal polyuria. To repeat, nocturnal polyuria means 130% of the total bladder capacity for its age. These children fail to increase the AVP production at night, thereby increasing the volume of urine produced at night. So I told you it's a mixed etiology with a complex interplay of three main things. I'm talking about primary monosymptomatic nocturnal enuresis. That is, one is nocturnal polyuria, reduced nocturnal functional bladder capacity. The bladder capacity is reduced at night. And then impaired arousal from sleep in response to a full bladder. These three factors are contributing in various proportions, leading to primary monosymptomatic nocturnal enuresis. So while we treat, we have to address all the three things. So it is important or pertinent for us to identify what is the underlying pathophysiology, whether it is nocturnal polyuria or reduced nocturnal functional bladder capacity, that the child needs to be tackled so that we can choose the appropriate treatment modality. Now, in the case which I presented, I told that the father has a history of nocturnal enuresis, which subsided by the age of 10 to 12 years. So that brings us to the point that is there a role of genetics? Yes, genetics plays a crucial role in nocturnal enuresis. Like in allergy, if one parent is affected, there is a 40% chance of the child having bedwetting. And if both the parents are affected, the risk increases to about 70%. And the gene that has been implicated is ENUR1 gene. It is an autosomal dominant trait, and there is 90% penetrance with complex genetic heterogeneity. So there is a role of genetics that is leading to nocturnal enuresis. So we have known about what causes, what are the pathophysiology of enuresis. Now, what is the impact? Is it necessary for us to treat enuresis? Like a common notion that it will improve by age. Nothing needs to be done. Is it really true? No. Enuresis has a significant impact on child as well as the family. It is a very distressing experience. It is said that it is the third most traumatic event after divorce and parental fighting. And some have even said that the experience is even worse than being teased and being ridiculed. So it is a very distressing experience to the child, also to family at times. There might be some unhappy or unwarranted words that have been passed in the family because of the child's habit of bedwetting. So it is very necessary for us to identify enuresis and manage it appropriately. What it also does to the child is it increases the risk of low self-esteem, impairs the emotional state, leading to social avoidance behavior in this child. These things are not temporary. Enuresis might improve, but the child who has developed low self-esteem and his emotional state has been altered, he may take a very long time to recover from this or may not even recover at all. So that is why we know that enuresis has both short and long-term impact involving both the child and its parents. And the long-term impact is predominantly psychological impact. Hence, we need to identify problematic enuretic children and treat it at an appropriate time. So what is the present scenario? What is happening all around the world and especially in India? Only around 31.9% of the parents of children aged between 7.5 years have consulted a health worker telling that bedwetting is a problem. Because many of them feel that they will grow out of it. They feel embarrassed to express this complaint. They believe that cause is emotional or behavioral, the child is voluntarily doing. And there is also a fear of blame or perception as they be poor parents. And also they believe that nothing can be done and the child will outgrow it. All these things are false to some extent. Yes, quite a few of them grow out of it. But who are those who grow out of it and who are the children who require treatment need to be identified. In India, the condition is much worse. Only 20.6% were given some form of treatment and 7.4% of these had some drug treatment and some 13% had non-pharmacological treatment like some home remedies or behavioral therapy like alarm and water restriction during evening time. So there is a significant lacunae that we are not identifying enuresis appropriately, and those in whom we have identified, treatment also is suboptimal. So it is our responsibility as healthcare providers to pick up these children and involve other stakeholders like parents. If the child is staying at a hostel, the warden of the hostel, these people have to be educated about the problem of enuresis, and they should be the people who should be forcing the parents or they themselves trying to get attention of the physician on this problem and getting cured. So how do we proceed with this? This is a very simple algorithm. Like any disease approach, we have to approach enuresis by taking a detailed history and examination. Few basic investigations like urine routine and microscopy needs to be done because most often the secondary cause of enuresis is urinary tract infection or some urine concentration abnormality related to certain renal disorders, which can be noted down with a complete urine examination and microscopy. After this, non-invasive urodynamics. I'll repeat, non-invasive urodynamics. Yes, bladder diary and USG KOB are considered as non-invasive urodynamics. With this, a lot of disease can be picked up and they can be categorized into two types. One, those with nocturnal polyuria and those with normal voided volumes. So, if there is a significant abnormality noted on ultrasound, or if there is a other symptoms not only related to bladder, like if there is a bubble involvement and other things, then we may have to refer the child to a much sophisticated setup like a bedwetting clinic. Otherwise, the basic management of nocturnal primary monosymptomatic nocturnal enuresis can be done at the primary physician level. So let us proceed the evaluation step by step. While evaluating a child with nocturnal enuresis, few things that we should not miss is one, we should have a questionnaire which will tell us about the frequency of bedwetting, symptoms suggestive of any underlying bladder dysfunction like lower urinary tract symptoms, presence of any comorbidities like obstructive sleep apnea, constipation. What are the drinking habits of the child? Whether the child is consuming more water, psychogenic polydipsia is there, or is it consuming more osmotic rich fluids like Mirinda, Coke, etc. and other things during the night time. And is there any previous history of bedwetting also is important. While we examine the child, a special mention should be made on the anthropometric parameters. It's very pertinent to examine the genitalia and the underpants to look for any structural malformation or also of if there is any incontinence features either of the bowel or the bladder. Inspection of lumbosacral region is a must, and urine dipstick, as I told you, is a must. A rectal egg palpation and neurological examination can be done in where it's deemed necessary. So after obtaining this history and physical examination, we need to have a detailed bladder diary. How to do it, I'll come up in the subsequent slide. So during that factor, what all we need to concentrate on? When did the bedwetting start? Whether there was any history of dry by night for a period of more than 6 months. What is the bedwetting pattern? That is any frequency, urgency. Is the child passing urine less than 4 times in a day? Is there any stream problem? Is there any abdominal straining? Is there any issue associated with stool passage? What is the fluid intake? What is the volume and the nature of the fluid? Are there any comorbidities like developmental attention, learning difficulties, behavioral disorder, and not to miss diabetes mellitus, which itself can cause polyuria. So all these information should be noted down. And then the most important tool in our armamentarium is a bladder diary. A simple bladder diary I have mentioned, shown here in the figure, which tabulates the predominant fluid intake during the day and night and the urine that is passed during the day and night needs to be mentioned with appropriate time. What is the kind of fluid that the child has taken and how much drink it has taken, and similarly what is the quantity of urine. So giving a measuring cup to measure the urine, sometimes it might be arbitrary, and that is not acceptable, because to define nocturnal polyuria we need to know what is the exact amount of urine that the child is passing at night. Now the doubt is, during the daytime, the child might voluntarily say that it has to pass urine because it has attained day by day. Now that if it is bedwetting, how to measure the urine at night? So what we suggest is to use underpads at night and weigh the underpads at night, and the first void volume the next morning should be added to the weight of the underpads. That gives the total urine production that night. If the total urine production during the night is more than 130% of the total bladder capacity, it is nocturnal polyuria. We also have to make a note about the accidental leaks and the nature of the stools passed, because as I told you, bowel and bladder have a common etiology and sometimes the pathobowel mechanism proceeds together. So that is why whenever a child has a constipation, invariably the bladder is involved. So it is very pertinent for us to maintain a chart of the stool output as well, and it has to be according to the Bristol stool chart, like the nature of the stool that is passed also should be mentioned. So the bladder diary should be done on 2 complete micturition days, so that it is to be done on a weekend when the child stays at home, and gives a 48-hour picture, like how much is the total volume that the fluid has the child has taken, which can even rule out or rule in the amount of fluid that the child is taking. That means if there is a psychogenic polydipsia, we can make a note from the bladder diary. And if there is a nocturnal polyuria or a daytime polyuria, or if there is any other issues, can also be noted down. The bladder capacity also can be noted from the bladder diary. See, as I already said, the nighttime urine production should be registered by weighing the nighttime diapers in the morning and adding the first morning voided volume. This I've already mentioned 2-3 times. If the nighttime urine production, which should be recorded over a week period to diagnose eventual differentiation between a nighttime urine production, which is more than 130% of excited bladder capacity, versus a nighttime overactive bladder. That means a functional reduction in the bladder capacity at night. So if a child was presented to us with primary monosymptomatic nocturnal erysis with a thorough history, examination, and a bladder diary, we will be able to differentiate them into 2 categories. 1, those with nocturnal polyuria, those with normal bladder, no nocturnal polyuria, but with reduced bladder capacity, functional bladder capacity at night. These are the 2 categories. So this differentiation is important to select what is the therapy that needs to be given. Before starting therapy, there are certain prerequisites that we need to look into. What are those? Whether the child and caregivers view enuresis as a problem. This is very pertinent. If both the child and the caregivers are not interested to identify enuresis as a problem, then the therapy will not give rich dividends. The therapy is definitely going to be a failure, no matter whatever form of mode of therapy that we choose. So we should know how strongly they are willing to participate in the treatment program. It is also pertinent for us to assess whether the child is mature enough to assume responsibility for treatment, because the therapy here involves a lot of motivational behavioral therapy. If a child development is not so good, then we will not be able to achieve the primary target that we have set. And our treatment modality depends upon what should be our treatment goal. Because if it is a short-term goal, like the parents and the child wants a drive by night for only next 2 days because the child is going on an excursion, or the parents are taking him to a family function, then a simple drug therapy might work. However, if it has to be a long-term cure or a long-term therapy, then the mode of management will be totally different. I should highlight here that treatment should be delayed if it seems that the caregivers are more interested in the treatment than the child. Sometimes the child is not willing, nor it identifies that enuresis is a problem. It's only the parents who are bothered about. The mother is concerned that the bed smells of urine, she has to wash the clothes repeatedly, and that is what bringing you to the clinic. Then those kind of children need to be first counseled and told that enuresis is a problem and how significant is that problem, and then gain their confidence, involve them in the management, and then only our treatment modality is successful. Otherwise, we have to wait until the child is mature enough to understand what the behavioral and therapy that we are advising to the child. So we should make sure that this is very important prerequisite, that the child and the caregivers are ready to undergo therapy for primary monosymptomatic nocturnal enuresis. So after we have identified a suitable child and the parents who require therapy, the treatment proceeds in the following step. First, always treat a coexisting condition. Try and identify if there is any constipation and treat it. If the child has sleep disordered breathing, like example I told you, OSA, or child has attention deficit hyperactivity disorder, that needs to be addressed first, followed by a behavioral intervention. That is by dry bed training and motivational therapy. What is this dry bed training? We may have to advise the child to reschedule its oral fluid intake. what I mean by that is the child has to take the predominant fluid intake during the first half of the day, from morning till say afternoon 2 or 3 or even 4 o'clock, 4 p.m. The child has to take almost 80% of his fluid requirement. The next half of the day after 4 p.m., only 20 to 30% of the fluid intake should be taken by the child. But the total day's oral fluid intake should be equal to what the child's recommended for his age and weight is suggested. Second, the habit of passing urine prior to going to bed should be inculcated in all children who are having enuresis. Few children are very reluctant. No matter they have passed urine 1 or 2 hours prior to bedtime, they have to make it a habit to pass urine just before going to bed. Third and most important one is, there is sometimes the child is being scolded by the parents or the caregivers for passing urine at bed. This is a very negative way of approach. This would never yield a positive outcome. In fact, it further worsens the scenario, and we have to strictly condemn this practice. If the child has remained dry, then by doing a positive reinforcement, by giving a simple star or a sticker for a smaller child or some other incentive for a much bigger child, would improve the compliance of dry by night. But a child who has been blamed or ridiculed in front of its sibling will not yield any dividends. So that should be kept in mind. Sometimes conditioning therapies using enuresis alarm systems. It may be an automated alarm system, which I'll show you in the upcoming slides, or a manual alarm system. This is manual alarm system means the child is made to wake up at regular intervals during the night and asked to pass urine voluntarily in the toilets, so that the child gradually learns the sensation of a full bladder and starts waking up by itself. But this therapy is little cumbersome because it interferes with the sleep cycle. Both the child as well as the parents lose their sleep, and it's not so very common with the parents. They are not so happy. They are not when we suggest this therapy alone. However, if this therapy is followed, the long-term improvement rates are much better and the relapse is less common. If all these therapy has been tried for a duration of a minimum 6 months and with no clinical improvement, then only we should proceed with pharmacotherapy. The options we have is desmopressin and anticholinergics and imipramines. So I have already highlighted what is this dry breath training and motivational therapy. To brush through, waking the child on a schedule of decreasing intervals over several nights, avoidance of dairy products, fruit juices, and fluids before bedtime, motivational therapy, which combines providing reassurance, emotional support, eliminating guilt, and rewarding the child for dry nights. And as I said, motivational therapy alone can resolve enuresis in up to 25% of the cases. This should be tried at least for 3 to 6 months before giving pharmacological therapy. So according to International Childhood Continence Society, there are 2 first-line therapies. If I said first line, I have considered that all the comorbidities have been treated and behavioral motivation therapies have been tried, and then any of these 2 therapy can be tried. Which are those? Desmopressin or alarm therapy. There are 2 strategies. Strategy 1 is using a voiding chart and identifying whether they have nocturnal polyuria or the bladder capacity is low. If they have nocturnal polyuria, the first choice will always be desmopressin, because the child has a pathophysiology in the form of reduced AVP production at night. So we are supplementing that at night, and thereby urine production at night is reduced. If the problem lies with the functional reduced in the bladder capacity, that means the volume of urine produced at night is normal, but the bladder is relatively small, functional volume reduction, then alarms are the better form of therapy. Sometimes combination of both may be necessary. The strategy B is the family is given the choice to choose either of the therapies. So what is this alarm therapy? I have shown a schematic figure here. It is an automated alarm therapy. Manual alarm therapy we have already discussed. where there are sensors which are inserted into the child's inner garments, and this gives a vibratory stimulus, so that when there is a wetting of the garments leading to the sensor picking up that stimulus, the child is waken up from sleep. This conditions the child to a sense of full bladder and wakes up from sleep. This leads to the child developing a sense of full bladder later on, and the child starts remaining dry by night or gets up during the night to pass urine. This requires a significant parental involvement and has a lot of sleep disturbance involved in this procedure. As I told you, it's not very favorable, not favored by parents, because it disturbs the sleeps of the child as well as of the parents. Having said this, we have been reading about this alarm device quite some time. Its availability is definitely limited. Very few tier 1 cities, the availability is there. It has improved in the last decade, but still the availability is sparse. So the management proceeds in these two ways. So we have two options with us, alarm or desmopressin. You choose either of the therapy based on parental preference, or as I told you, strategy A, based on your bladder diary, we can choose either desmopressin if they have nocturnal polyuria. If they have a functional bladder capacity low, then alarm therapy. Try and follow up once every fortnight and look for improvement. If there is an improvement, continue for a duration of 3 to 6 months, or if the patient has remained dry for 14 consecutive nights, and then try discontinue. Here in alarm therapy, there might be occasional relapses. If there is a relapse, we can resume treatment again. However, in desmopressin therapy, though I have mentioned a dry for 14 consecutive nights, a minimum duration of therapy for desmopressin is 3 to 6 months, and then we can start tapering. Don't discontinue abruptly, because relapse rate with desmopressin is very high compared to the alarm therapy. The long-term outcome with use of alarm therapy is much, much better compared to desmopressin. If on follow-up, either of the therapy is not giving sufficient target achievement, then we may have to reevaluate, reconfirm whether it is monosymptomatic nocturnal enuresis, and then consider treatment. If we are sure that it is primary monosymptomatic nocturnal enuresis, we can club the treatment, both alarm and desmopressin, or refer to a specialist. At any point of time, if we identify there is any features of lower urinary tract symptoms, it should undergo a detailed evaluation, including an invasive urodynamic study to rule out bowel bladder dysfunction. So in the next couple of slides, I will stress the importance of desmopressin. It is a synthetic analog of arginine vasopressin. Unlike arginine vasopressin, desmopressin has no effects on V1 receptors. It only has effects on the renal V2 receptors, which are present in the distal convoluted tubules and the collecting ducts of the kidney, thereby causing reabsorption of water in these tubules and leading to decrease in the urine production. As it does not have any V1 receptor effects, it doesn't have a vasopressor or uterotonic effects. So it has a rapid onset of action, and the duration usually lasts up to 8 hours. It is the only pharmacological agent with grade A class 1 recommendation, and the response rate has been documented as high as 70%. As I already mentioned, relapse rates are pretty high. Hence, slow withdrawal with reduction in dose is recommended than abrupt stoppage. So desmopressin forms the first line of management if the families choose this therapy who are unable to comply with the alarm. So children with nocturnal polyuria and normal bladder capacity volume are more sensitive to desmopressin, and of late, with extensive studies, we have noted that desmopressin is remarkably free of adverse event even on long-term use. So who are these patients who are at risk for treatment resistance? I told you the behavioral therapy itself can reduce by around 25%, up to 70 to 80% with the use of either alarm therapy or desmopressin. Still, another 5 to 10% of them will remain resistant to therapy. In them, we need to look for the following factors: whether it is non-monosymptomatic nocturnal enuresis which has been missed, whether the child has any overactive bladder, they have a concomitant constipation, dysfunctional voiding syndrome, insufficient desmopressin dosing, or there can be a individual variation in the desmopressin pharmacodynamics leading to concentrating capacity abnormality, and comorbid psychiatric and other conditions. These things have to be addressed if there is a treatment failure. So treatment failure or treatment resistance is if you have used the therapy at adequate dosage for a duration not less than 6 to 8 weeks with not even a reduction in the symptoms. There may not be a complete reduction in the nocturnal enuresis. Sometimes the frequency might reduce from all 7 nights to 3 nights in a week. That is also some form of improvement. So though the target may be to attain try by night on every day, even the reduction of symptoms, a partial response also is considered some improvement with the treatment therapy. If they have not attained even partial remission or partial improvement, then these are the things that we need to look for. I did not mention the dose that we are using for desmopressin therapy. We can use 2 formulations. One is a conventional tablet form. The other one is an oral disintegrating form. That is a mouth dissolving tablet which can be placed on the tongue or under the tongue, which disintegrates. If it is a conventional tablet form, the dose starts somewhere at 100 or 200 micrograms, and up to 600 micrograms we can uptitrate based on the response. If it is a oral disintegrating tablet, the dose required is much lesser. We can start with 60 micrograms and uptitrate at 30 mics and reach even as high as 240 micrograms. Sometimes if there is no response with both alarm and pharmacological therapy, so combination therapy may be preferred, and this is in those children with nocturnal polyuria with small bladder capacity. In them, the combined therapy is which works better. So this is in a nutshell. Whenever we encounter a child with nocturnal enuresis, take a detailed history and examination and a non-invasive urodynamics. I would like to stress the importance of bladder diary and a ultrasound KB again. Divide them into whether the children have nocturnal polyuria, whether they have a reduced functional bladder capacity or a normal voided volumes. If there is an abnormality noted with a USG or any other non-monosymptomatic features present, then we may have to perform a uroflow and then based on it divide the bladders into whether it is an overactive bladder, dysfunctional voiding or unclear diagnosis and proceed further. This actually is the work of a specialist, and the specialist team includes a group of physicians, surgeons, psychologists and so on. So what are the red flag signs for referral? If there is a suspicion of structural or anatomical abnormalities, any non-monosymptomatic enuretic child, associated developmental attention and learning difficulties, behavioral or emotional problems, known or suspected physical or neurological problems, and refractory enuresis. These are the kind of children who need to be referred. So what are the way forwards? It is to have the concept of bedwetting clinics. It's something novel in Indian scenario. Just prior to the initiation of this talk, I was discussing one of the doctor in Ahmedabad designates a day in a week to counsel children who are having this problem. So we can come up with the idea of bedwetting clinics, which functions as a specialized setup for children with bedwetting, having a specialized mechanism for evaluating and managing bedwetting. It includes pediatric nephrologists, pediatricians, urologists, child psychologists, psychiatrists, and nurses. They can act as a referral centers, which provide a thorough evaluation and management, which can be a boon for children who are facing with the distress and frustration associated with this condition. So I'd like to conclude my talk with this following take-home message. Nocturnal enuresis is a common problem affecting school-age children and often under-recognized. Voiding diary or a bladder diary is a very important tool in evaluation of enuresis. If there is one single thing that I would like to stress upon today's talk is that please try to develop the habit of maintaining or explaining the parents who present with enuresis to maintain a voiding diary. It gives a lot of information. Both caregivers and healthcare providers should play a proactive role in addressing this problem, as it can have long-term social impact. If we can remember or go back to the case which I presented, the mother had a concern that the child is not having such a good socializing behavior like its peers. That is a red flag sign. This child necessitates treatment. I would say that the child was 8 or 9 years old. There is still a chance of spontaneous resolution, but the child has already started to develop psychological problems which have a long-term impact. So that child definitely requires some form of therapy. So treatment should be guided by therapeutic goals. I stressed upon it. If it is a short-term goal, then few medications would bring about a necessary target achievement. However, to achieve long-term goal, have standardized protocolized way of management. First, to address the comorbidities, next to try behavioral and motivational therapy, and then one of the either first-line therapy, that is either desmopressin or alarm therapy, should be done in a systematic way. Desmopressin has proven to be safe and effective in management of primary monosymptomatic nocturnal enuresis. Thank you for your patient listening.
Okay.
Very informative talk, Dr. Shashikiran. Thank you so much.
Thank you, sir.
One thing is, what about the nasal sprays? Desmopressin nasal sprays.
Yes, sir. Desmopressin nasal sprays are now out of use. In fact, they have been now no more used for this indication. Nasal spray was the one which was more notorious to cause hyponatremia.
Okay.
We still use, sir. I still use nasal sprays occasionally, but that indication is for the platelet function benefit of the desmopressin. In scenarios where we are doing biopsy and there is a uremia associated platelet function disorder, there I'm still using nasal spray occasionally, sir. But that is only one shot. We give it 3 to 4 hours later, we do a biopsy and we don't repeat the dose further. So the chance of hyponatremia occurring is a little less likely. Here in this scenario, if you are using nasal spray, we'll have to give it daily, sir. And there is a high risk of hyponatremia being developed from it. So now we don't recommend nasal spray. I've mentioned here, Minirin, this company, the Corona Remedies brand name, which was approved in 1980, is now discontinued since 2020 because of the notorious side effect of hyponatremia.
Okay. One more question, Shashi.
Yes,
what percentage of pediatric nocturnal enuresis children have gone into adulthood with the same problem? How common is it in adults?
Yeah. So somewhere between 1.5 to 3% according to the studies, sir. But sir, we can pick up these children as early as 10 to 12 years. Because those children who are going to have a spontaneous resolution will resolve by the age of 10 to 12 years. Those which are persisting beyond 10 to 12 years tend to go on and persist beyond 18 years and become adulthood enuretic individuals.
Okay, Shashi. Thank you.
Yes.
May I, Dr. Shashi?
Yes, sir. Please.
That's a good presentation. Quite impressive. I think you really conveyed right from pathophysiology to where all we need to intervene and how to really, I think like what you said, there's a lot of hand-holding that is required. The family needs to be constantly motivated and then reassured that adhering to the approach will definitely bring about the meaningful outcome. Would you like to throw some light on imipramine group of drugs and anticholinergic? Because and also make a mention about the cost of desmopressin therapy, considering the fact needs to be given for about 3 to 6 months. How expensive is this treatment?
So the cost, I will ask Mr. Vasu to update on it, because it's not pretty very costly, sir. Few of the patients which are under my follow-up, I have put them on it. He'll give the updated cost related to that. With respect to the use of anticholinergics and imipramine, sir, earlier, sir, during our undergraduation, post-graduation days, these were the drugs of choice. However, they come with a baggage of problem associated with systemic anticholinergics. They have their own side effects like dry mouth and other autonomic problems that it comes in, anticholinergic effect that it comes along with it. We have an alternative in the form of safer option like desmopressin, which does the job which the body is failing to do. That is urine concentrating ability. So that has now moved from the lower down option to being the first line of choice. Anticholinergics and imipramine does come into the picture for those children who have a hyperactive bladder and who have failed therapy with hyperactive bladder, or who have already been put on the 2 conventional first line therapy and they have failed. So as a last line resort, multiple combinations we will be doing. So that time we tend to use cholinergics as well. To add a note, urologists are very fond of using anticholinergics compared to nephrologists.
I can understand that. Okay. Right. That's a good way to really look into it. I think what was a frontline mode of management pharmacologically earlier, now it's become a fallback option, suppose anything else fails. Okay. Right. Thank you, Dr. Shashi. Anybody has any inputs to provide?
Mr. Vasu, if you can highlight upon the cost of the tablets as well as the melt form.
Sir, the cost of therapy starts with around 1,452 per month, and which will go up to around 2,400 per month.
You're telling for the 60 microgram tablet, 60, right?
60 will cost per month is around 1,452. And if we go for a 120 and a higher dose, that will cost somewhere around 2,400, sir.
Okay.
We start with 60 micrograms, sir, usually, and with 30 mics, we up titrate based on the response. So 1,400 is the beginning per month, is the beginning cost.
Okay. And definitely it's worthwhile, like what Dr. Shashi mentioned, having something like the concept of having a bedwetting clinic at least once in a month, so that we can put all these families together and also create an opportunity for support group meetings so that they can reassure each other and motivate each other to be compliant with the treatment, because the treatment is a little prolonged one. Many a times, for lack of motivation, they are likely to be treatment dropouts, which can be significantly minimized. And give a thought whether something like this can be done either in medical college setting, MMC, or JSS, and we should really consider this on a very serious note.
Yes, sir. The idea of having professor and heads of the departments of 2 medical colleges from Mysore was to indirectly convey that we are willing to offer help to set up a bedwetting clinic in either of the medical colleges. I think definitely we'll be happy to provide my skill there, and I'll request the Corona Remedies people to help us with the logistics involved with it.
In fact, it is a very good suggestion, sir. So the Department of Bedwetting under the Department of Pediatrics will be a great idea if IAP can come forward and take this initiative ahead. And from Team Corona, we would like to 100% support and address all the necessary requirements. And in fact, we can have ICCS accreditation also for that department.
We'll discuss about it, Shashi. Sure.
Thank you so much, sir. With your permission, sir, there are a few questions in the chat box. Can I take it up?
Please.
Age to consider for treatment. By and large, there is no cutoff age. There are multiple factors that need to be considered prior to initiation of therapy. For a child who is 5, 6, 7, or 8-year-old, we tend to believe that there is a possible chance of a spontaneous resolution as the child grows up. But if the child has developed already a social isolation behavior, if it is affecting the psychological, if it's affecting psychologically the child, then we may have to intervene early. So age, though I wouldn't say there is a cutoff, but I can give a rough guideline. As I said previously, most of the milder disease which has to reduce subside by the age of 9 to 10 years. So after the age of 10 years, the prevalence is relatively stable. So these are the ones who are unlikely to resolve spontaneously and needs therapy. So by the age 9 to 10 years is when we will intervene with therapy. But if they have other effects like psychologically it is impacting the child, we may have to start therapy as early as 6 to 7 years old. One of the guidelines from European or Canadian, I don't remember when I was going through, by age 5 itself, the treatment is recommended. And significantly, this is done because particularly if they have siblings and the other sibling has attained drive by night, this child will definitely get psychologically affected from it. So the therapy in management should be initiated early. So there is no hard cutoff age as such, but it can be used 9 to 10 years as a rough guideline. But if the psychological effect is already there on the child, then we have to consider treatment very early. Second, how long treatment to be continued? Treatment with pharmacotherapy, that is desmopressin, we have to start it with, as I said, 60 micrograms at the night. Melt form is the preferred one with very little water is required because it's mouth dissolving. The basic idea is we have to advise the children to take less water. So this melt form is the ideal one. And we have to uptitrate it every 2 to 3 weeks based on the response. Even if there is a partial response, that is a reduction from daily or a 3 to 6 times, 3 to 6 nights a week to a 3 or less than 3 wettings per 3 nights per week, then we have to consider it and treat for a minimum duration of 6 to 8 months before considering stopping. And we should not stop pharmacotherapy abruptly. We have to titrate the dose, like how we do for steroids when we are using it for a duration lasting more than 2 to 3 weeks. We have to halve the doses of it gradually every 1 to 2 weeks and then reduce it so that the relapse is less common. Age and treatment response, if any. I think you like this question. Age and treatment response, you mean to say treatment response is better in which age group? I don't think age is the factor which involves the response to therapy. Basically, it depends upon what pathophysiology we have identified and what modality we have chosen. If the pathology was nocturnal polyuria, then the response with desmopressin will be definitely good. If the volume void during the night is normal, but the bladder capacity is low, then probably alarm therapy is much better. And alarm therapy alone also may not work at times. So that time we may have to add on a desmopressin therapy to it. And the response which is better, I told you, for a short-term gain, pharmacotherapy always has an upper hand. But if it is a long-term game with less chances of relapse, where you are conditioning a child to the sensation of full bladder, then alarm therapy is better because of long-term outcome with it. But one catch is there, significant sleep affection is there with alarm therapy. Thereby, both the child as well as the parents are not so fond of this therapy. Side effects, I just mentioned. By and large, there is very minimal or very few side effects with desmopressin. Some taste or alteration or might be the minimal thing, that's all. Even that has come down with the new formulations. And now the dose we are using is almost 1/4 of what the tablet form which we are using. So the side effects are very minimal, but only one thing we need to keep in mind, along with desmopressin therapy, we should advise them to restrict fluid intake at night. Don't get me wrong that we should not restrict fluid intake. Fluid intake per day should be according to his age and weight and sex. That is there. But we have to reschedule the fluid intake so that it gets 60 to 70% of the water requirements or fluid requirements of the day before 4 or 5 p.m. and then only the 20 to 30% of the remaining portion after 5 p.m.
Okay.
Okay. I hope the question.
Dr. Shashikiran,
Yes, ma'am.
some patients will, my parents are not bothered much about enuresis, but they'll ask for a short-term relief when they go for their relative's house or when the child has a camp. So can we prescribe desmopressin for few days like that?
Yes, ma'am. Desmopressin we can prescribe, but the response from them is it's not a scale-based response, ma'am. We may not be. I with my personal experience, I'll tell you, ma'am. There are some 4 children probably now since the last 6 months or so. 4 children whom I have put on this desmopressin therapy. Medform only I've used. 2 of them have attained complete dry by night. 2 of them complete. They from 2 days from the time of starting of therapy, they have attained complete dry by night, and they are just on 60. Whereas the other 2, one of them is still having 3 or 4 wets in a week, and the other one took a very long time to respond. Now with around 120 micrograms, he is only having partial response. So we are not sure whether desmopressin alone would be sufficient for them. It will not assure that they will be dry by night on the subsequent 2 days. The response is varying, ma'am, based on those responses.
Okay.
But can we give? Yes, we can try.
Thank you, Dr. Shashi. I think you made the evening very interesting for all of us. I'm sure if it's agreeable to our professors in both the medical colleges, I think we should consider doing this more often, get a lot of our specialists and faculty come up with some of the commonly encountered day-to-day clinical scenarios so that we can share, learn, and also exchange ideas with each other. I think on that particular note, I'd like to thank everybody, including Dr. M.R. Prashant, for having given me this opportunity to be with you all, and Dr. Shankar Prasad and Tripti all there. Thanks. I think I once again thank Shashikiran for having made a beautiful presentation.
Thank you, sir.
Crisp and clear presentation, Dr. Shashikiran. I'm sure the doctors, especially we were just thinking of primary and secondary enuresis as pediatricians, monosymptomatic, non-monosymptomatic. These are the other things, especially bladder diary, that we don't have a concept as a pediatrician. I think these are some of the newer points which we have understood. And I'm sure our management will change after listening to your lecture. It was a good lecture, Shashikiran.
Thank you so much.
Thank you.
There is another message in the chat box. I think Dr. Marini has congratulated. It is very informative talk. And on that note, I think I can just say good night and leave. Thank you. Thank you, Dr. Shashikiran.
Thanks.
Thank you, one and all. Thank you,
Thank you,
Shashi. Good luck.
Thank you so much. Thank you one and all for the opportunity, sir.
Thank you, Shashikiran sir, and thank you all the dignitaries. It was a wonderful evening and wonderful experience to hear from the experts, and definitely it will be made a day for with a new learning for many of the pediatricians who are not currently practicing bedwetting or PNE as a management option in their regular practice, and definitely it will add or inspire them to start definitely. Thank you, Shashikiran sir.
Thank you, Vasuji.
Thank you, sir.
Thank you so much.